practice. We have that problem. And of course, in today's debate, we have chosen some of the important subjects in each specialty, like cataract, that's a bread and butter, and also glaucoma, retina, cornea, and everything. Of course, I have to thank all the moderators, I have to thank especially Dr. Venkatesh for making this happen. He only did all the formalities of inviting speakers and topics, etc. And also other moderators like Pani Selvam. He voluntarily come to debate on cataract. Cataract is a common thing. To do SHS with Haripriya. So really, it's a wonderful opening, this thing. And also the Rajasekhar, Professor Rajasekhar, Armuli Varman, and the speakers. Of course, Pani Selvam and Dr. Madhavi and Bhaskar and Deepak, Sriram Gopal, my dear Sriram Gopal, and so many wonderful speakers on this occasion. Welcome, Mohan Rajan, you made it. Super, thank you. You are the real hero, no? Yeah. So in that way, I'm very happy to invite all of you for this wonderful evening. And we have our President-elect, Dr. Nirmal. I request Dr. Nirmal to say a few words, and then I will hand over the podium to Dr. Venkatesh, who will be doing all the... Yeah. Nirmal, yes.
Thank you, President sir, and all the members here, Dr. Mohan Rajan sir, Dr. Arul sir, and all the senior functionaries of TNOA and the participants of the big fight. So the year starts with the big fight. Let me wish you all a very happy, healthy, prosperous new year. So a nice way to learn the various aspects. So this entire 2 hours, I think it will be a useful deliberation for all our members, and also for us to learn some key points, and hopefully we'll arrive at some conclusion with the debatable points. So I wish the program success, and hope to see all of you at the mid-year meeting at Kutralam. So thank you all. Thank you, President.
Yes, I forgot. Thank you, Nirmal. I take this opportunity to invite all of you to Kutralam for the mid-year meeting in January 28, 29. Don't miss it. Thank you. Thank you, Ramu. I hand over the podium to Dr. Venkatesh, please.
Thank you, sir. I mean, I appreciate all the fighters who have joined us, on the New Year Eve, on the year 2023, to debate some of the important topics. Now, some are in our regular practice, some are new to our practice, but still, I think it's good to have a evidence-based fight here, so that at the end of the day, we all learn from what evidence talks to us. I mean, that is more important in patient care. So we'll start the first fight between, I would say debate between Dr. Haripriya and Dr. Pani Selvam, who is a very senior ophthalmologist, and both have terrific experience in their own field. But the topic is ultra hard cataract. Now, what would I like to do? And we'll start with Dr. Haripriya, who says, I always want to do phaco.
I hope you have the emergency kit and ambulance ready, Venkatesh.
We have a big judge also there.
He is a partner now. Yeah.
Thank you, Dr. Venkatesh and TNOA for this opportunity. So yes, phaco is the way to go for ultra hard cataracts. So the world is moving towards technology, as we all are aware. And the World Economic Forum says that India is meant to be the world's fastest growing economy in the coming year. And this will probably fuel the need for demand from everything from cars to television, coals and airlines. And we can't be left behind with cataract surgery. Currently, phaco accounts for about 50% of what is done in India. It was about 10% not too long ago. So this is a massive uptake of phaco in the country. And besides the growing economy, other reasons for this increase in phaco acceptance is that cost of phaco machines and consumables has reduced significantly. So more of the population now have access to this technology. So why are we considering phacoemulsification in these ultra-hard cataracts? One, again, I think a couple of years back, I think this would be a cataract for SICS, but today we have a lot of good options in terms of technology. We have much better phaco machines with good fluidics and better tips. And various surgeons have also shared different innovative techniques of how to emulsify these hard lenses through a small rhexis by breaking the posterior plate by causing less endothelial damage and thus giving the patient good outcomes. We also have excellent OVDs available today. So these patients, in spite of having lower endothelial cell loss, in this population who have hard lenses, the patients can have a good outcome. The other most important factor is that the benefit of IOLs. This to me is probably the most important reason why one can consider phaco, because many of these patients in this aging population have high astigmatism, they may have other needs, and we can give these patients, post-op 6/6 if everything else is fine, by having a predictable surgically induced astigmatism and toric IOLs wherever it is indicated. And again, for even the more complex cases like the hypermature cataracts, where the capsular rhexis can be a challenge, to do an SICS through the small rhexis would be a challenge, we all agree. And to do a large rhexis is not going to be easy with the raised intralenticular pressure and weak on use. So phacoemulsification, again, thankfully with advances in techniques and technology, is now a choice we can give patients even in these situations. And why should we deny any patient the right to see better? Why not give them the best possible outcome by giving them the best vision? This patient basically had astigmatism of about 1.25 diopters. And so a toric IOL was placed and the patient did well. At 1 month post-op, the patient had 6/6. At 1 day, of course, there was some corneal astigmatism, which resolved with a couple of days, and the patient did well at 1 month. Now, there was a recent review from the Tirunelveli Aravind group, which looked at the preferred practice of cataract surgeons in brown lenses. Of this, I think 230 ophthalmologists participated, and 198, a majority of them said SICS is the first option. And the reason why they said this was because they think there's a high risk of complications with phacoemulsification. The other factor is that most of them who do SICS, most of them also use a superior incision. 70% go for a superior incision. Now, do we actually see a higher complication rates in phaco? So this paper published by the Madurai Aravind Eye Hospital looked at 959 eyes of luminescent lenses, of which 654 underwent SICS, and the rest underwent phacoemulsification. The phacoemulsification group had a complication rate of 2.95%. And SICS group had a complication rate of 5.96%. And if you break up these complications and see what they look like, so half of these complications were because of PC rent in the SICS group. A big number also had a zonular dialysis, which we see a lot more with, in these large luminescent nuclei in SICS, where the patients also tend to have zonular weakness. Another important complication is the high risk for iris dialysis, which again can happen because of the brown lenses. One doesn't see the iris, and this can also be a risk factor. So besides complication, the visual outcome was also looked into. And at 1 day, while the difference in vision was not significant, at the 1 month follow-up, the patients in the phaco group saw much better, about 6 by 9.5 versus 618 in the SICS group, unaided vision. This was the mean vision. So I think this is the most important take-home message, that patients who undergo phaco in these cataracts, this is the luminescent cataracts, do see better at 1 month, and that is what is the most important message. At Aravind, we most of our patients, 97% of our patients undergo phacoemulsification today. The other 3% either because the patient had already had an open capsule or had just a lens removal or patients couldn't afford. But most of them today, phaco is done and is possible. And why do we choose phaco? One, because the BCVA is, if you look at the outcomes here, the BCVA is comparable between SICS and phaco. If you look at the 612 and better group and the 618 and better group, it's comparable. But how about the uncorrected visual outcome? So 618 and better. I think most RCTs which publish their data look at this bracket of 618 and better. Here there is a difference. SICS patients see 80% see well, which is great because I think this is important. But I think functional vision should be 612 or better at least for them to have their routine activities possible. And there's a big difference in what SICS would offer in comparison to phaco. So I think, and even more, when you look at patients who have 6/9 and better. This is data from 2022 Jan to June. And the other aspect is, when you think about SICS, you think about the incision size, large incision. So we are always thinking larger is safer. Is that true? So my husband wanted to, he now drives a Ford, and we were looking at different Ford options, and we were wondering if the larger Ford is safer. But data doesn't seem to agree. It says that the Ford Expedition 2, which is a much bigger vehicle, has a higher driver death rate. And this is because there's a higher chance that the car may tip over. So, and how does this work in terms of cataract surgery? I think it's quite true. With large incisions, you may have various other problems as well. It may take longer to heal. You have more issue with regression, higher astigmatism, high chance of wound complications like premature entry, which means more chance of hypotony. The other factor is you have to have a large rhexis in these patients, which means that during surgery, there's a high chance of rhexis extension. The other thing is that, you may have a difficulty in making these large rhexis in these eyes, which have weak zonules, and many of them may also have small pupils, whereas phaco, you can do a phaco through a small rhexis. Now, one is the outcome, but in terms of safety, we think SICS is a safer technique, but is it always true? Now, this is, I think, one video which shows that not necessarily. SICS large tunnel attempted, but there is a nucleus drop here. And it's just not the nucleus drop, but various other complications. So we saw in the earlier slide as well, there's a higher chance of zonular dialysis. So here, the nucleus is stuck, in spite of the large tunnel here, which is going to take a while to heal, plus there's a large dialysis as well. So is it really worth it to do an SICS in these hard cataracts? We also saw that many of these patients, when the hard lenses, when we try to do a nucleus extraction, we may not see the lower edge of the vectors. And what can happen? You can strip the iris root, and there's a large iris dialysis, and the patient is scarred for life. So a large SI is done, and the iris and the pupil is disfigured in these patients. So I think to sum up, there are about many publications which looks at comparison of phaco and SICS. And this interesting Cochrane review looks at only the RCTs which compare phaco and SICS. And they say that the odds ratio has a 2.48, indicating a better outcome using phacoemulsification. And both techniques, the complication rate is low. And they also mentioned that in view of the cost, maybe SICS can be considered in some of the economies like India, Nepal, and South Africa. But do we also, do we want to believe them and continue to give our patients, substandard quality is something which each surgeon has to think for themselves. So if you have not already made the transition to phaco, I think it's important to remember Charles Darwin's quote that it is important that one has to be adaptable to change. Otherwise, the species will not survive. So give the best to your patients, the new technology, where the outcome is better and the patients are also better satisfied. Start with the best option, which is phaco. Why do we always say start with phaco and convert if it doesn't work? We don't say start with the larger incision and convert to a smaller wound. We always want to give the best option. If it doesn't work, then you can go to the next best option. And finally, I think it's a matter of time before all surgeons make the transition. So don't deprive your patients the best way for them to see better following surgery in a hard lens.
Thank you, Dr. Priya. I think Priya is making a call that with the improvement in the technique and the technology, we'll have to explore this for any type of cataract. And we have Professor Dr. Paneer Selvam, who is going to antagonize that talk.
Good evening, all of you. I'll share my screen. So the debate is on phaco versus SICS in ultra hard cataract, not for the cataract surgery. So in an ultra hard cataract, what is the safest and what is the best that we are doing? There is no way for the economy to come. We always think about SICS as poor man's phaco. That is not the right thing. And you are given 6 minutes time, Dr. Ramakrishnan, but I think I need only 15 seconds to prove my point. So just this video, I think this will be enough. So why we need such a arduous procedure to do a simple thing, taking out a nucleus? The important thing in cataract surgery, apart from the advent of IOL, I feel is the self-sealing wound. So this self-sealing wound is a major discovery, and all other things are an value addition to it. So in each cases, we have to decide. Look at this, the psychology of risk-taking. Recently, you would have read in a newspaper, 3 people drowned in a US lake. They fully know the danger of going in because the danger sign was there. They left the shore. They went in, the ice cracked, and they drowned, and they could not be saved. What do you call this? Reckless, foolishness, overconfidence? I feel it's irresponsible. Knowing that the ice is always dangerous and the danger sign, but we want to explore that, experience that. Is it yielding to the temptation is a major point. I feel doing a phaco in an ultra hard cataract is similar to that. We all know the challenges in ultra hard cataract, the big nucleus, the fragile zonules, associated pseudoexfoliation, the pupil might be smaller, and there will be the anterior chamber depth will be sometimes very shallow. In all these cases, is it why to do phaco? Look at this. The visibility will be not very good. Dividing the nucleus is always tough in an ultra hard cataract, and associated complications like posterior capsular tear, zonular damage, and endothelial corneal endothelial damage, and all this, and especially for a new surgeon doing a phaco, it will have a wound burn. And all these things should be really going for that. And the amount of time that's taken and the amount of fluid that goes into the eye, is it really wise attempting that? I feel the Tirunelveli survey, the surgeons wisely decided to go for manual exercises, not because they are not talented, not because the cost effective, it is the safety part. So ease of SIC, there is no such any nonsense there. We just a big incision. Big doesn't mean bad. It's safe, yes. And in the post-op aesthetic medicine doesn't come with an external big incision. It is the way in which you fashion the internal wound is the major point. How you fashion it, people miss on that. They either go more anteriorly or they go into the, they don't restrict the incision to the corneal side. This is the way. When you go in, you go. When you come out, you don't cut. In that way, you can keep the internal opening within the corneal area, and thereby you can minimize. And you can do a very good rexis, a bigger rexis, yes, it will be better. And you can prolapse the nucleus with two-hand technique. So reducing astigmatism has got a lot of ways. And it is not always you do the iridodialysis or a nucleus drop in those cases. It's much more safer for the surgeon and the patient. Prolapse the nucleus fully into the anterior chamber. Either you can use an irrigating vectis or a sandwich technique. So this lens has come out, cortex aspiration and lens. And SICS doesn't mean that because you have made a scleral tunnel incision, you have to put a rigid lens. If the patient wants a premium lens, nobody stops you from putting that lens. So that is another misconception that people have there. So this is the result that you get. So research evidence also. Venkatesh has published one beautiful paper where he has compared phaco with manual SICS for white cataract. And he has not said SICS is bad. He has compared all the results are really good. And he was very apologetic. It is good for the developing countries and for the charity patients. I don't know why he has to be apologetic. This is the mindset that has to change. And Haripriya has given her own study in Arvind, where she has compared the phaco surgeons of senior surgeons with fellows, trainees, and visiting trainees. And in all these fellows and visiting trainees, where the experience is not that good, the manual SIC is much better than phaco. The complication rate in phaco. In a normal cataract, so they have that much complication. In a hard cataract, you can imagine what will happen. This is what I think. And recent publication in a review article in AIOS, the corneal endothelial changes following cataract surgery in hard cataract, the ECD changes are more. So the cornea might be improved in a few days' time. What will happen after 5 years? These are the questions we have to answer. A long-term study is needed. So why then phaco? Phaco mainly it is not an economic advantage or visual improvement. It is pride. I have the machine, I have to operate, and I will do this. And if I do SICS somewhere as a surgeon, I feel low. This is that. And like Dr. Haripriya said, there is a bias towards technology rather than concentrating on the technique which gives a better result. And there is commercial consideration because naturally with phaco only you can go. Maybe multifocal lenses may not be possible, but this happens to a very old patient. And sometimes the patient themselves will have unrealistic expectations. If we have to play the doctor, which is best for the patient, not because somebody has got the premium lens, they want to pay more, we have to attempt to phaco. And this premium business is really bothering. And it creates a confusion among the counselors to promote the premium surgery, thereby forcing the surgeon to do phaco in a very ultra-hard cataract. And there is always a thing is, we always look for validation from the developed world. This we have done, so many people have benefited, but we don't have the pride in owning the technique. But I'm running a small training program. I get a lot of people from other countries. Now there is a trend towards learning SIC. They are all well-established phaco surgeons, VR surgeons. They want to learn. So this is for your information, Dr. Haripriya. Listen, we don't have to be apologetic for doing SIC. So horses for courses. Look at this patient. Hard cataract doesn't come overnight. It takes years and neglect. And what is the best for the patient? Choose what is the thing. And you should also know what you are good at. If I'm good at phaco, if I have all the technology, attempting is nothing wrong. I'm not against phaco. I'm also against doing 2 millimeter SIC. The SIC is not meant for this gimmicks. It is only for a safer. And what is the correct technique? I feel SIC is the correct technique. And there is a misconception that every patient wants emmetropia. That is also a thing that I don't agree with that. So my choice will be for an ultra hard cataract. It is always SIC. Thank you very much.
Thank you, sir. I mean, it's so nice that you said large is not always bad. You know, when it comes to an ultra hard cataract like that, when you have patients coming in from a rural background with a lot of delay in cataract getting done, I'm sure we need to explore this. Because of want of time, we'll have one of the moderators. I would request, is J.K. Reddy there? If not, Mohan Rajan sir, you want to say a few words before we go to the next one?
Yes, Venkatesh.
I think, can I say a few words?
Yes, sir.
I think both of them did a very good job. I think it's important to select the patient and what type of patient, and also what type of technology, what is their experience, and what works best in your hands. And I like the last word of Dr. Paneerselvam, put the patient's safety first always. And whatever you're comfortable, whether you're comfortable with FACO or SICS or whatever it is, I think that's the take-home message.
Thank you, sir. Any quick rebuttal, Priya?
Yeah, so I just wanted to say that sometimes, people are considered reckless, but I think all pioneers are first considered reckless, but that becomes the norm and then people accept. So I think people will follow soon. And I also feel that surgically induced astigmatism is not reliable on SICS. So any option of toric and multifocal
No, it's okay.
may be a challenge.
I'm a cold-blooded.
Bad idea to go with a toric lens or a multifocal lens in patients with SICS. And also the astigmatism you induce. You have to remember that these patients, most of them have at least a diopter of astigmatism against the rule. And most surgeons go superior, so you're going to increase it from 1 to 2, 2.5. So they'll have 618, 624 needed. So those things are also something which you have to consider. And so they will have a higher astigmatism in most surgeons' hands who do SICS when dealing with hard lenses.
Reddy, you have a minute before we go to the next talk.
Many points, unfortunately, I don't agree with Dr. Haripriya. Doing superior section, I don't think there is a small surgeons trained from particular centers. They are only doing superior sections SICS. The remaining entire world is doing temporal SICS. So they don't want. Most of the surgeries are done through temporal SICS. Except
for the survey, sir. The survey had ophthalmologists.
Yeah, the survey maybe you localized to some particular area.
It's an all India survey that was. That's what AIO is, IJO.
Most of them are temporal SICS only nowadays, very rare. And it helps some against the rule astigmatism. It neutralizes better than FACO. And it works very well. There is nothing like astigmatism is unpredictable in SICS. Very, very, very predictable. Highly predictable in astigmatism than in MICS. When I saw many cases operated by other surgeons, even MICS, they say that they burn the wound and the astigmatism very unpredictable. And coming back, pan-India, I support, I am with Paneerselvam sir, still I do. If it is a brown, I want to have a peace of mind, sleep comfortably. We are past 55 years. We don't want to disappear in the middle of the night. We just do SICS. We want to live few more years. If it is a brown, as cataract as you have shown, or Paneerselvam, we just go for it. And technology is available, I accept, but very, very expensive. Every 5 years, you need to buy a machine for 1 crore rupees and do a brown cataract. Impossible. You cannot run India. Even America is collapsing doing like that.
Thank you, Reddy.
Can I make a quick point?
Yeah.
In support of Haripriya. See, there's a large piece of furniture in a room. It won't go out through the door. So do you dismantle the furniture or you break open the wall?
Tricky question, Gopal.
Large piece of furniture is there in a room. You dismantle the furniture and take it out piece by piece, or you break open the wall, you take out the furniture intact. Which do you want intact, the furniture or the wall?
How did that furniture went into the room first?
It was dismantled and taken inside, sir. So you dismantle it and take it outside.
Yes, grown inside.
The same logic will work in a different way. Now, where you cannot dismantle something, okay, whatever reason, Like I still remember somebody breaking a wall to take a phaco machine inside their hospital because they can't, they're not phaco machine, it's a LASIK machine. Now I still remember it was in Tirunelveli, Agarwal or somewhere because I saw them breaking and taking it inside. So it happens when you have to do that, you'll have to do it because you want to safely take that inside or outside. But anyway, we'll go to the next topic for want of time. This is another interesting debate because we know minimally invasive glaucoma surgery is quite popular in the Western world now, but we are also picking it up. But we are going to see whether it's got a role in mild to moderate glaucoma. So we'll have first Dr. Unfortunately, Devendra is not here, but we have fortunately Dr. Madhavi, Devendra's colleague, who is going to talk about phaco mix for mild to moderate glaucoma. We are talking about combined surgery here. We are not talking about standalone procedure. Yes, Dr. Madhavi.
Good evening, one and all. So at the outset, I would like to thank TNOA for giving me this opportunity. So I'll be stepping in for my MIGS teacher and my mentor, Dr. Devendra Maheshwari. So cataract with mild to moderate glaucoma. This is the exact and perfect case scenario where MIGS fits in beautifully. MIGS may be an ant when compared to an elephant-like trabeculectomy, but we all know ants can be really powerful in their own domain. So the question we should be asking ourselves.
Just give me a second. Is everybody seeing the PowerPoint disturbed or it's only with my vision here?
Yeah, I think it's got to do the streaming most probably.
Yes, yes, it is disturbed. It's
Can you stop and reshare, Madhavi, quickly? Can you stop?
Yes, sir. Yes, sir. Yes, sir. I'll do
Stop the share, close the PowerPoint, open the PowerPoint again, and then share. This is very rare. I've seen a disturbed slide like this, even though your streaming is, because your streaming looks good. No, it's still the same. Still the same. I don't understand why.
Mostly something to do with the screen resolution.
Sir, I'll just close and reshare, sir. Just give me a moment.
Okay. Beyond that, if it is not coming, it's fine. You continue.
Anything in the settings in the Zoom?
இல்லங்க ஜூம்ல எல்லாம் இந்த மாதிரி நான் பார்த்ததே கிடையாது இது வரைக்கும்.
ஆமா ஆமா. ஏதோ சப்டைட்டில் பிரேக் ஆயிடும் இப்படி வராது.
ஏன்னா உங்க ஆடியோ பிரேக் ஆகாம வெளியே even slides won't go like this, but this is something interesting. I mean, you can't even read what is there in the slide.
So maybe give me a moment, sir, or maybe the next speaker can take over while I.
We'll ask Dr. One of my good friend, Dr. Bhaskaran Mani, consultant in SN, to go with the other side of it. Now, I would still do a phaco trap than doing a phaco mix for mild to moderate glaucomas. Yes, Dr. Bhaskaran.
Are you able to see the screen, sir?
Yeah, perfect. But I think we're seeing the final slide.
That's what I'm trying to figure out, pushing it up. Okay. Yep.
Yeah.
All right. Thanks, Dr. Venkatesh and the team of TNOA Big Fight for inviting me for this first fight of 2023. Happy New Year to all. So the topic is cataract with mild to moderate glaucoma, phaco trap versus phaco mix. So I'm trying to represent here the old wise and the experienced topic here. I don't have any financial interests, absolutely no, because it's trabeculectomy. So let's go ahead with the topic. Epidemiology representing the stage of glaucoma in India. So 90% of glaucoma in the country remain undiagnosed. Well, most of the patients come to us with very advanced stage and severe disease. So in which mix obviously as of now doesn't stand a chance. Once cataract surgery is done, the follow-up is often poor as well. So they end up coming back to us at the severe stage. And again, a primary angle closure disease represents almost half the population where mix doesn't have any role, as of now at least. All procedures, I'm talking about the combined procedures, by the way. All procedures have been compared. I'm talking about procedures in the sense mix, with phacoemulsification alone and not to phacotrabeculectomy. So we know that the established combined procedure with conventional trabeculectomy and antimetabolites have been quite effective in terms of long-term IOP control. This is the typical scenario that we are talking about: a patient with 32 to 28 millimeters of mercury, open angles, and on 2 anti-glaucoma medications, not controlled, intolerant to medications, and with cataract. And what would be the best thing that is possible in this case? Let's talk about the elephant in the house. Why not go with medications and just cataract surgery alone, and or SLT, which is cost-effective, best visual rehabilitation, least risk, long-term visual field loss. We don't know about that, but there are some evidence-based, for this kind of scenario. Of course, once these kind of patients are taken off, there is a small group of patients with mild moderate glaucoma where you would probably want to do phaco mix when the patient can afford to it. I think the rest of those, probably 9 out of 10 patients, might require phaco trab only. Let's also look at some evidence. Why not SLT? This is the 6-year result. Time to disease progression, time to glaucoma surgery, time to phaco emulsification, all have come down. So in that cases where the phaco mix is a possibility, is stolen by SLT or a preservative-free anti-glaucoma medication already, when a cost is the biggest prohibitive factor in our population. After all, we are only paying by rupees, not by dollars. And even in those countries where they are paying in dollars, the number of mix that is done are coming down, except a few procedures. Let's look at some Cochrane-based evidence on cataract surgery versus combined surgery. So mean IOP difference, this is the 2015 paper that I can find. It says that the IOP difference, medication difference are all very mild when compared to just cataract surgery alone, while surgery for surgical complications are slightly higher in the combined surgery group. That is what I'm talking about for avoiding even a combined procedure. Now let us look at those patients who require a combined procedure. These are the types of mix approaches: KDB, iStent, which are available in India, which are a bit costlier. GUT and BANG with the 5-O-proline, of course, are representing the cost-effective procedures, but there are doubts thrown on trabecular meshwork destruction in these kind of procedures, even though it is getting more and more popular. Now, what are the indications of mixed mild to moderate glaucoma? These are all the 3 representative groups, and I talked to you about a very small portion, but the contraindications go a long way, wherein a phaco trab would do better. So majority of these patients who require combined surgery require a phaco trab. Let us look at it from the patient's perspective. I think many of you would be interested in financial aspects, so you would know. Let us look at it from the patient's perspective. He is investing his cost and time in this surgery, which is like a security, basically the surgery or intervention experience, and he wants a return on investment, basically the intraocular pressure control, vision, visual field stability, and quality of life, and with minimal risks. You can't avoid any risk for that matter, complications, resurgeries. We want low risk. So whether phaco mix and phaco trab have a difference in this or not is something which we can look at it from the evidence point of view. Let us look at from the investment point of view. The patient obviously has to pay a high premium for mixed procedures compared to trabeculectomy, which is lower because we don't use any devices as such. And in terms of intervention experience, phaco trab has higher experience, obviously, as of now. Times may change, but we are talking about at this present time period. Return of investment, obviously, in terms of efficacy, in terms of visual field stability, by that way, the quality of life possibly is high with phaco trab. We will show some evidence on that as well. So efficacy, that is return on investment. Look at phaco trab. Our experience as well as some international experience looks at low teen intraocular pressure with trabeculectomy at 5 years at least, while 2 to 5 years of follow-up, this is actually 2 years, this is 24 months, you are looking at either nearing 15 millimeters of mercury or high teens in most of the mixed procedures. Now that is where it stands, 50 to 60% drop in IOP with trabeculectomy, and in mixed procedures around 20 to 30% drop in intraocular pressure. So that is where the return on investment is. Looking at the risk factors, you can see the single-digit numbers on these dreaded complications where some intervention is required in the early period itself. However, looking at device implantation problems or obstruction problems or ifema, you can see that there are quite a number of these issues. I'm talking about in terms of further interventions or patient's vision getting blocked in the immediate post-operative period. And of course, in terms of long-term vision complications, there may be slightly more issues with phaco trap, but with safe trabeculectomies being practiced nowadays, these complications can be easily avoided or at least tackled fast enough with proper training. Look at this early and late onset hyphemas with MIGS, somewhere between 12 to 80% with the procedures that are available in India. Expectation at first post-op week is a stroll in the park, but reality is with the hyphema, the patient has to be bedridden. Now that's where the trabeculectomy is. It can represent a wide range of stages of glaucoma, from mild, moderate glaucoma till late stage, to have a low target intraocular pressure, while MIGS represent a very small area in terms of whether it is combined surgeries or late procedures. And the experience takes it all. So resting my case would be low target intraocular pressure needed is better achieved with phacotrabeculectomy. Long-term adverse effects such as intermittent hyphemas are avoided. So in our scenario of Indian population where low-cost long-term IOP control is desirable, I would still prefer phacotrabeculectomy at this juncture. With due respects to the phaco mix and new technology, yes, we need to go for it. But at the same time, we need to look at what is important for our population at this juncture. Hopefully, with the time coming, the phaco mix might come into more and more of the scenario. But I think when you have a preservative-free multi-dose combination medications available and SLT as an option for such small group of patients, either doing a cataract surgery alone or a cataract with glaucoma procedure where long-term IOP control is desirable, I would go for phacotrabeculectomy, and I hope the panelists would decide the same way.
Thank you, Bhaskaran. I think you were a little optimistic about the phaco mix for the future, but it was so interesting to see how many times you used the word return on investment on comparing. It was looking like a financial talk for me at some stage, at least. Anyway,
the cost is what is mind-boggling when I talk to the patients about mix.
Exactly. Now, when you say the eye stent and cataract with eye stent will cost you a package of 100,000 or even more, sometimes you can see a sudden jerk there. I mean, can I get the result back for it? That is important. I mean, that return of investment is so important, but we'll have to carefully see how it works in some of our eyes and how the long-term results are. Can we guarantee that to the patient before we take a call? Madhavi, you can close your presentation, Bhaskaran. Yeah,
I'm just trying to do that.
Yeah, Madhavi, you want to try now again?
Yes, sir.
So you have to, if your presentation comes up, you have to tell us how to counteract the return on investment. It looks slightly, it's better now.
Better, sir? Yes, sir.
Yeah.
Yes, sir.
So,
phaco MIGS. So the cataract with mild to moderate glaucoma is the perfect case scenario where phaco MIGS fits in beautifully. So it may be an ant when compared to an elephant like trabeculectomy, but we all know ants can be really powerful in their own domain. The question we should be asking ourselves, why do people still go blind from glaucoma? Yes, it is still undiagnosed and there is a lack of compliance, but is it still being improperly treated? The various treatment modalities like medications, lasers, surgery like trabeculectomy and tube surgery comes with different set of problems. So there is this huge therapeutic gap which needs to be filled. So problems with medications include allergy problems, patient compliance, and itching, irritation, and lash growth, etc. With new medicines come new set of problems. So trabeculectomy has been the gold standard for up to 50 years, but has it achieved what it earned to achieve? The complication is around 40%, failure rate up to 50% at 5 years, and cataract formation in 50% at 5 years. Still, it is not golden so far. And when you consider some of the pre-op conditions where we actually need a glaucoma surgery, but is trapped with phaco is the best option for all these patients. For example, in patients with scleral thinning, conjunctival problems, staphyloma, patient with physically debilitating illness, we need to look at better options. So, And also during introp, the complications of trabeculectomy can hit you like a tsunami. You don't know what is happening at what point of time. You have to always be on the lookout for introp malignant glaucoma, introp suprachoroidal hemorrhage, etc. Post-op, the story continues with multiple interventions needed: blood needling, suture removal, suturolysis, digital ocular massage, etc. This is a headache both for the glaucoma surgeon as well as the patient point of view, who needs to come for multiple follow-ups. The TVT study had shown that tubes as well as straps comes with complications in early stages, late stages, and multiple resurgeries also. So the nightmares of trap does not stop with pre-op, intra-op, but it still goes on, and it can go on at any point of time. The patient can present with pictures like this.
Race clear.
So we needed a hero to rescue us from this scenario and to bridge the gap. This is where MIGS fits in beautifully. So what is an ideal glaucoma surgery? It should be as effective as the golden standard. It should be reproducible without blood. It should be easy to perform with less post-operative effect, and it should be cost effective. So MIGS manages to check most of the checklist with being an ab interno approach, being minimally traumatic with a good safety profile and a rapid recovery. It targets the trabecular meshwork Schlemm's canal outflow pathway. And what we didn't have before till now was the luxury of choice, and MIGS has managed to provide us glaucoma surgeons with the luxury of choice. So the device-based MIGS may be limited in India by their availability and expensive nature, but we have other options also, like the trabecular meshwork-based MIGS like GAT, BANG, and trabeculotomy, which are readily available and economically efficient at the same time. So this is a video collage showing the various MIGS procedures which has been performed in our institute. And the GAT, BANG, and the Tanito microhook trabeculotomy, especially, they are really economically efficient. GAT needs a 5-0-proline suture. BANG, it can be performed readily using a 26-gauge needle bent. So where is the evidence? So minimally invasive glaucoma surgery has managed to give significant intraocular pressure reduction as well as promising safety and efficacy. And the publications have gone skyrocketing. And even MIGS in the device market has managed to capture around 46.1%. This is a meta-analysis which shows over a total of 3,069 studies, which included 2,928 eyes, which has shown that MIGS is effective in lowering intraocular pressure, drug use, and good safety profile. But the point to be noted here is there is no cases of infection or best-corrected vision acuity loss due to glaucoma. When compared MIGS alone or MIGS with phaco, both manages to give good intraocular pressure control around 25 to 40% and a reduction of medication rate about 40 to 50%. So this is a study which showed outcomes of 2-year GAT, which showed a IOP reduction around 41.5% and an AGM reduction around 2.54. Again, the point to be noted here is there are no vision-threatening complications that occur during the 24-month follow-up. And this is a 3-year outcome which compared pseudo-exfoliation and open-angle glaucoma, and the results are impressive even in pseudo-exfoliation glaucoma. So the mixed spectrum does not stop with open-angle glaucoma. Now it has extended even up to angle closure disease, and there is good evidence that is coming up regarding its safety as well as efficacy in angle closure glaucoma. So every surgical procedure has complications. So which is the bigger complication? That is the question. Is it a hyphema or is it a choroidal detachment? Hyphema, yes, it is seen up to 70%, but it is easily manageable, and acute elevation of IOP in few cases. Peripheral anterior synecdoche and DMDs are very rare complications. To summarize, appreciation for the risks and complications associated with the traditional glaucoma surgery has ignited this MIGS revolution. It provides a safe option, as well as the main advantage is that it does not affect outcome of future incisional surgeries. It has managed to check most of the boxes which TRAB fails to check. In the future, it will become the first surgical choice, and maybe TRAB or tube will be reserved for cases where MIGS is not possible. Thank you.
Thank you, Dr. Madhavi. I think you put your point very nicely. You can stop the share. And when you even look grossly at the presentation, you would say that Bhaskaran's publications were more before 2015 and after 2015. In the last 7-8 years, all these evidences have come from MIGS, because this is something new. We are still testing the sea here. We are still testing a lot of things. I mean, we have to look for more evidence in this. And of course, in our own
Good evening, everyone. Thank you for this opportunity. Are my slides visible, sir?
Yes.
When this topic was given to me, my first thought was, what will my mentors think of me? Because we routinely do not use steroids, TPK post-fungal keratitis, as it is better for the patient to get a repeat optical penetrating keratoplasty following a failed TPK graft than having a graft melt in a failed TPK following infection. Then why did I accept this talk? Sometimes it is better to fight and lose the battle and create awareness than not participating in it. Also, I like to take this opportunity to thank the ARC team for giving a topic that is more relevant to our population. Not always we get a cornea looking like this post TPK following dermatitis fungal, and this is stuff. Now the big question is, will you start steroids for this patient? When we looked at the literature, very few there are very few articles here, and most of them are
Naveen, one quick point. Naveen, can you switch off your video and then keep talking?
Yes,
yeah. Just there is some problem in your bandwidth here. Just switch off your video.
Yes, sir. In this large case series, which studies the outcomes of therapeutic penetrating keratoplasty for fungal keratitis, they had used a good quality tissue and they had started steroids 10 to 14 days after therapeutic penetrating keratoplasty. 10% had recurrence. That was high rate of recurrence, and 1/3 of those patients who had recurrence lost their eyes. In spite of starting steroids, only around 10 to 12% of them had clear graft at 1 year. Another recent study studied the effects of topical cyclosporin 0.1% 6 times a day for 3 months post therapeutic penetrating keratoplasty for fungal keratitis, and they compared with an historical cohort where the patients were treated with prednisolone following therapeutic penetrating keratoplasty for fungal keratitis. Though there was no early recurrence, the follow-up period was short, and a long-term survival of the graft needs to be evaluated. When we look at the pathogenesis of corneal ulcer, we always concentrate only on the infection part and treat them with antimicrobials. We do not address the detrimental immune-mediated necrosis, which is also a part of corneal ulcer. Steroids have been beneficial in non-nocardial bacterial keratitis, and for bacterial keratitis, there are numerous antibacterial agents which achieve bactericidal concentration in the cornea, whereas natamycin, discovered in 1960s, is still the drug of choice for fungal keratitis, and most of them do not achieve fungicidal concentration in the cornea. Now, for the patient with unidentified dermatitis fungal keratitis who underwent TPK, we had started steroids 1 week after therapeutic penetrating keratoplasty, and interestingly, strange AC reaction occurred, wherein we could see the growth of fungal filaments in the anterior chamber, and the patient had to undergo multiple anti-chamber wash with intrastromal oriconazole and intracameral oriconazole, and finally the patient ended up with a failed graft. To conclude, if you are planning to use steroids post-TPK for fungal keratitis, have a high degree of caution for recurrence. make sure that there are no signs of reinfection, and most importantly for our patients, make sure that they are compliant to treatment and they'll come for close follow-up visits. Thank you.
Okay, that was a terrific presentation, Naveen. I think Prabhu will follow this and then we'll have a short discussion. Prabhu?
Yes, sir. I think, Naveen, please close your screen. Yeah.
Yes, sir.
Is my screen visible, sir?
Yes.
Yeah. So good evening, everyone. I'm here to talk about no postoperative steroids in case of fungal keratitis in requiring therapeutic penetrating keratoplasty. Thanks for this review article. While I was preparing, I saw this review article and I was shocked to see the volume of the single particular disease causing so much of burden on the world. Globally, about 1 to 1.4 million cases every year, and 73 per 1 lakh is the incidence. And about 84,000 to 1,67,000 eyes are lost for evisceration every year, and 6 lakh people go blind because of one particular disease, that's a fungal ulcer. And these three things which we know are very common, but these three are the important predictors for surgical intervention: the presence of hypophion at presentation of the patient, and infiltrate involving the posterior 1/3 of the stroma. And despite maximal therapy, if the ulcer, even if it is increasing by 1 millimeter in size, then we are mostly heading towards a therapeutic penetrating keratoplasty. We all know this slide that the steroids are strongly contraindicated in cases of treatment for fungal keratitis. That is because it itself is a single most important risk factor for the development of the fungal ulcer. And that is why the steroids have been used in animal models to for research purposes to induce in fungal keratitis. And steroids have been clearly proven to worsen the existing fungal infection for reasons we have already known. And with all the drugs except for amphotericin B, it has the potency to reverse the therapeutic effect of the drug. So for me, it's not like that I'm not, the topic is like something what I see this topic is like when you are not supposed to give steroids, then blindly saying it no steroids for all cases. So the main conception for me is the fear of recurrence of the infection. See, we are not dealing with cases which is early cases. Most of the time, at least 50 to 60% of the time, we are dealing with cases like perforated corneal ulcers or corneal ulcers with a lot amount of anterior chamber activity, and corneal ulcers involving or close to limbus or already involved in the limbus. So whatever the good amount of therapeutic keratoplasty we do in these cases, we are not 100% sure of complete microbial eradication. If we are not sure of a complete microbial eradication, then we are not justified in starting steroids in these type of cases. And we have a very good list of antifungal drugs, starting from amphotericin B, natamycin, voriconazole, and we have new additions like echinocandins, which are all very important for refractive fungal keratitis, and posaconazole also right now. But not all these things are without any limitations. They do have some amount of limitations. And we do see about 20 to 30% of the cases in the daily OPD that controlling the disease is still a challenge, and it does not respond to the medications at all. And we don't know what is the reason. Is it resistant to the antifungal drugs, a difference in vitro or in vivo susceptibility, or is a compliance issue? Or is there something called as a localized immunosuppression or systemic immunosuppression like uncontrolled diabetes and something like that? So having all these things in mind, when I was searching the articles, this article aptly stood me that this Shai et al. Also started fluoromethalone after 2 weeks, but they had a sizable number of infections, like 10 to 12% of their cases had infection. Majority of the cases had preoperative hypophion, corneal perforation, infection involving the limbus, and lens extraction were the major risk factors. And alternaria and aspergillus are the notorious organisms, and they are knowingly or unknowingly, if the glucocorticoids have been used in the pre-treatment before the ulcer, the 21% chance of infection was there. So when I think back, we have to always see whether which is safe for the patient and what I am capable of handling with. If I feel that in cases where there is an advanced infection and when the disease is uncontrolled with antifungal drugs, then the erroring towards the reinfection will be a very difficult task for me to manage, because I have to go for reserve drugs. I have to go for alternative therapy like intracameral and intrastromal injections, and mostly we will end up doing another surgery. Still, we are not very sure will be able to give anatomical salvage of the eye. In that case, the failing graft looks it's not a very big deal for me, that I can use the NSAIDs to control the inflammation and use immunomodulators to reduce the vascularization and use the anti-glaucoma medications to make the optic nerve heads viable. And always I have an option of doing a regraft PKP. And many of times, if in a properly done therapeutic penetrating keratoplasty, we have a good chance of doing a DSEC or a DMEC in the postoperative non-inflammatory phase of the disease after a year or so. And dealing with cataract will be straightforward in those situations as well. And second reason, beyond this first reason, which is the recurrence of infection, the second reason, which I would say with a pinch of salt, like that over time from 2001 to 2019, almost 3 to 4 different articles which I have seen, they have tried really good with fluoromethalone and other steroids in the postoperative period. But unfortunately, the graft survival rates are really not welcoming. Up to 2 years, it's fine. After 3rd year or 4th year, 5th year, very less number of studies are there. And the graft survival rate has drastically been less when compared in the long outcomes. And in case the graft failure rates is also high. This could have been this could have been the reflection of the use of therapeutic grade corneas as well. I do agree with that. So we are still at the verge of coming to a decision that we need more research where we can use optical grade corneas and judicious case selection, and then we have to come to a conclusion. Right now, I think that the risk-benefit ratio in cases of starting steroid, in cases of an advanced disease, is still on the riskier side. And so for me, the conclusion is I lean towards a no steroid therapy in advanced cases. The cases where the disease is progressive even beyond maximal possible medical therapy, notorious organisms like Aspergillus and Alternaria, and poor socioeconomic status, poor compliance, or poor follow-up of the patient. I do have a small subset of patients where I can think of starting steroid. First of all, what the main important criteria which I want is a response to an antifungal medical therapy. I'm able to demarcate the ulcer and stop the ulcer from further progression. That is what first thing which I want. But I am not able to heal the ulcer completely or scar the ulcer with antifungal drugs alone. And there is a necrosis in the center with the inflammation, and the repeat cultures have become negative. So I have planning to go for a therapeutic keratoplasty with the optical grade cornea. In that case, the button culture becomes all the more negative. I'm very happy. I would be with a good clearance margin. I would definitely think of adding steroids after 2 weeks with the fluoromethalone, and even scale up to Predfort in the long run. But I need a good patient who is a good compliant patient with a good follow-up, who is understanding the risks of starting a steroid in a post-operative regimen. So right now, with a major disease, I am lean towards the no steroid regimen. Thank you, and I am open for discussion.
Thank you, Dr. Prabhu. I think we'll open it for discussion. I mean, anybody who's practicing cornea, I'm sure J.K. Reddy is now back in the limelight. You want to say anything, Dr. Reddy?
Yeah, I'm here only just switched off because of the video, bandwidth, all those issues. For the see, both of them, this is the first time these guys you said fighting, they are not fighting. It looks like they are friends. Both of them showed the same conclusion. Both of them said no steroids, and rarely we use steroids, and when you use steroids, you get trouble. So you use very cautiously.
Debate mara illa there.
Rendu, I think both of them, they came to their say they don't want. So they confused us. Actually, they confused the audience. They are debating or they are talking the same.
That's why I begin saying that they are real fighters. They only fight physically.
On the ground, physically, not on the professionally. So coming back to the steroids used in fungal keratitis, it's very much debatable after TKP, not as an ulcer. As an ulcer, most of them, they don't never use it. And after TKP, the golden standard is wait for a month or 6 weeks. If by 6 weeks you don't get recurrence of evidence of clinical recurrence in the graft in slit lamp examination, of course, not microbiological. In slit lamp, you don't have any evidence of recurrence by the of the other. Then start on steroids in a low dose and increase it gradually. That's what we are following. Most of them, they are quite good. Recurrence are very late, but you have to allow for a month almost. Within a month, usually it's very rare to get rejections. So anything from the audience?
Okay. Dr. Rajsekhar, you want to add? I know you're a retina specialist, but still you want to add anything?
Yeah, true, Venkatesh. I also concur with JK. Listening to both the debaters, I find the side is tilted towards no steroids. And even if you do a big PR exercise and get all our opinion, referendum of all our colleague doctors, I think most of them will be joining the bandwagon of no steroids. I think that will be the fight end.
Yeah. Any point about the previous debate?
About the glaucoma.
Yeah.
Glaucoma. I think previous I was listening, the thought that was coming to my mind is previously the glaucoma talk will be whether to go for medication or to start do a trabeculectomy. Now we have evolved and come to a stage where we are saying whether we are going to do a trabeculectomy or we are going to do MIGS. And in that, I think probably down the line, MIGS might catch up, but at least at this point of time, a trabeculectomy is the safe and sure solution for this kind of a patient. I think that is how the debate also was. I think the person who was speaking about the trabeculectomy was more convincing to me.
Okay. Before, yeah, like what you said, we usually debate between drop and chop. Now it is becoming chop versus you stent or eye stent or suture inside. It's becoming more like an interventional cardiology or radiology where you're trying to put something into a canal and make that better. But we'll have to wait for long-term results like what Mani was saying, because we know the gold standard 50, 60-year-old, and we have seen results. And in the best hands, the complications are much, much less. And we have seen that also from evidence. So is there anything else on the corneal topic? Anybody else want to add anything? Is our chief judge there? Okay, I think he's in the trade now. Let him enjoy the trade, and we'll go to the next topic. Frederick, I promised the retina team to finish before you, so we'll have to go with the retina topic. First line treatment for diabetic macular edema with hard X-rays, and we have a very young ophthalmologist who is going to really fight against my good friend Gopal. Dr. Arthur, first you will go with intravitreal steroids. Vignesh, you can throw the light after the discussion. இப்ப நல்லா தான் கேமரா நல்லா இருக்கு, அது இருக்கட்டும். நீங்க பேச வேண்டியது அப்புறம்.
Yes sir, sure sir, thank you.
Dr. Deepak, எங்கயோ சுவிட்ச் ஆஃப் பண்ணிட்டு போயிட்டார் போல இருக்கு. சரி கோபால், I think why don't you go first with intravitreal anti-VEGF? We'll let him join.
Thank you, Venki. I asked somebody to call Deepak to wake him up.
Okay, fine.
See, this is the problem. If you give him a topic like this, he's so scared he doesn't even want to be online. Not fair.
He's thinking it is in the last. That's the problem. Maybe he's not aware that we have preponed it.
He was online when we discussed that, actually. No problem. Okay, so I've been asked to talk about anti-VEGF versus intravitreal steroid, and there is a small rider there saying in the presence of hard X-rays. I'm going to tell you how, whether that point of whether hard X-rays is there or not actually doesn't matter. So this is going to be something of a showdown between a Han Solo and a Luke Skywalker. I'm sure people who follow Star Wars will understand what I mean. So in the pathophysiology of DME, lot of things are involved, inflammatory mediators, leukostasis, VEGF.
Gopal, can you go to slideshow? There's still an issue in getting your slides.
My slideshow is on and it
Abdina,
is...
Okay. Stop share and reshare.
Do it again. Maybe I'll close that app and open it. In a second.
Deepak, we are going next with you.
I'm here, sir.
Okay.
It's just my headphones were not working. I was trying to talk, but it was not
No
coming.
No problem. You can go after Gopal. Adukulla Gopal, you odi pittinga.
Can you see my slide now?
Yes, Gopal. No, வந்துட்டே இருக்கு. No. என்னாச்சு? வரல கோபால். ஃபுல் ஸ்லைடு சோ வரவே இல்லை. இப்போ எதுவுமே வரல, blank-ஆ இருக்கு. இப்போ ஸ்லைட் சார்ட்டர்ல இருக்கு. I don't know why.
இப்போ once I go to full screen, it says your slide sharing is paused. I don't know why.
Okay, then you go with the individual slide, but make it bigger, slightly bigger. Zoom it up, little bit, zoom it up, and then go. Yeah.
So take this.
And you take the full screen to your computer and then go on.
Yeah, I think that will be better.
Okay.
Full screen should be somewhere here.
அந்த ஸ்லைட் ஷோ ட்ரை பண்ணி பார்க்கலாம். I think it's okay, Gopal. You can go on.
Okay, so let me give one last try.
Sure. Illa, should we allow Deepak again?
Let him go on. Let him go on.
Yeah, okay, Deepak.
Okay, sir. I'm just sharing my screen. Is my screen visible now, sir?
Yeah, go to slideshow. Yeah.
Is it in slideshow now, sir?
Perfect.
Okay. Shall I start, sir?
Go ahead.
Okay. Good evening, everyone. Sorry about the delay. There was a small connectivity problem. I could hear you speaking, but my headphones was not working. Thank you, everyone, for giving me this opportunity. I thank TNOA for taking me in for this grand debate. So at the outset, I would clarify on the topic that was given to me: intravitreal steroid injections as the first line treatment for diabetic macular edema with hard exudates. So I do not have any financial interest. And let's be clear about the topic. So it's not just any macular edema. Everyone knows when there's a macular edema related to diabetic retinopathy, anybody would go for an anti-VEGF injection as the first line. So here we have a small catch. If you see the end of the topic, there is a small word which is hard exudates. So is it just the same? Or is macular edema without hard exudates and macular edema with hard exudates the same, or are they different entities? Obviously, they have to be different entities. That is why it has been given as a separate topic of interest. Diabetic macular edema, as we all know, is a multifactorial complex disease. It's driven by a host of different factors, right from hypoxia to inflammation, hyperpermeability, and different factors leading to angiogenesis. So all these factors have led rise to the macular edema. And this entity called hard exudates is what we are really worried about at this point of discussion. So why does it happen? It's because of accumulation of lipids and lipid-laden macrophages. And studies over the years have clearly proven that diabetic macular edema associated with hard exudates is known to have poorer vision outcomes. So what is this hard exudate and why is it bad? So it has also been shown that it is a sign of recalcitrant macular edema. And the presence of hard exudates per se is shown to block the interaction between the neurosensory retina and the pigment epithelium. So when there are hard exudates, especially at the macula and at the fovea, it somewhat prevents the normal interaction of all the chemical mediators between the pigment epithelium and the neurosensory retina. And long-standing hard exudates per se are just going to go sit on the fovea leading to subretinal fibrosis and scarring, which is going to have a permanent effect on the visual acuity of the patient. So where do we see this scenario? Any chronic diabetic macular edema is going to have a lot of macular hard exudates, and even post multiple anti-VEGF injections, we can see the worsening of the number of hard exudates which are present, especially around the fovea. And we know that anyone with a deranged lipid profile is going to have a high number of hard exudates. So what is the role of anti-VEGF agents in such patients? As we all know, gold standard in reducing macular edema is any day anti-VEGF agents. But what is their role in hard exudates? We know that it reduces subretinal and intraretinal fluid, but several studies have been done. Though they have given contradictory results, most of the studies have clearly shown that they do not have a very significant role in reducing the number or the size of hard exudates. So even studies have shown that they have been seen to aggravate or increase the number and intensity of hard exudates because of the rapid resolution of fluid. There is accumulation of these lipid-laden macrophages, leading to increase in the number of hard exudates. So what happens? Rapidly the fluid gets reduced. There's foveal migration of hard exudates. This foveal migration is a term that I think we would have even heard from the days of lasers for macular edema. When lasers are done and the fluid comes down, the hard exudates had tended to move to the fovea. So that is exactly what happens, especially when you have parafoveal extensive hard exudates. And those hard exudates tend to go settle down at the level of the RP, at the fovea, at the subfoveal level, leading to scarring and permanent visual loss. So now coming to corticosteroids. Why corticosteroids? Per se, their effectiveness in reducing diabetic macular edema has well been proven. And so many studies have shown that they have a much faster resolution, much faster resolving effect on the hard exudates. And this in turn reduces the risk of subfoveal fibrosis, leading on to permanent visual loss. And how do they act? They have several mechanisms of action, the commonest one being reducing the inflammatory mediators. And they also inhibit the other pro-inflammatory macrophages. They stabilize the blood-retinal barrier, thereby enabling the transport which hard exudates had previously blocked. And they also induce differentiation of anti-inflammatory macrophages, which in turn help clear up the hard exudates at a faster rate. Advantages and safety profile. I'm sure Sriram sir is going to say, steroids have their own risk factors, wages are going to go up and so much. But as we know, the newer long duration implants and their safety profile has well been documented. Mild intraocular pressure changes do happen, but they could well be controlled with anti-glaucoma medication. Cost factor, as we all know, the newer anti-VEGF agents are much costlier than the steroid preparations, and frequent administrations are not needed in the long-standing steroid implants. So why steroids in diabetic macular edema, especially with hard exudates? We need to bear our primary goal clearly in mind, because visual improvement is what we are looking for. And resolution of fluid and hard exudates at the same rate is very important in the treatment of such a diabetic macular edema, which we have clearly seen happening with steroids and not with anti-VEGF agents. So to conclude, you want to have your fovea scarred, you can go ahead, take your anti-VEGF agents as your first line. And once it's scarred, you really can't do anything about it. Or you want to save your vision, you can go ahead with a steroid implant, and you know that the hard exudates are going to clear up, and then you can have your vision and your fovea saved. So you need to choose wisely and let your patients have the benefits.
Thank you, Dr. Deepak. I think the stage is set for Gopal again. Do you want to scar the retina, or you want to give vision to the patient?
He'll have to stop sharing his screen, actually.
Yeah, Deepak.
Okay, can you see my screen now?
Yes, perfect.
Okay, good. Thank you. So as I told you, this is going to be something of a showdown between Han Solo and Luke Skywalker. So Star Wars enthusiasts will know what this means. the problem. Yeah. So we know that diabetic macular edema, like what Deepak said, it involves a lot of things. And the only problem with using steroids is it targets only one of the small things called inflammatory mediators. Whereas we know that VEGF plays a very important role in the pathophysiology of DME, and not only DME, even diabetic retinopathy as such. So if you're looking at a patient with diabetic retinopathy and think that he's only going to get macular edema, you're highly mistaken. There is something else more serious going on called proliferative retinopathy, and the VEGF is the only one which blocks both. So when you treat a patient with DME, you're also treating his diabetic retinopathy. Don't forget that. The patients treated with anti-VEGF for diabetic retinopathy do not progress to proliferative retinopathy. They are more or less likely to develop PDR. And also there is a significant improvement in the severity score of diabetic retinopathy when they are treated with anti-VEGF for DME. So that is one point. The second one is the weight of evidence, the plethora of evidence which is for, let us say, anti-VEGF. It is not there for steroids. Ask him to show me at least 4 robust double-blinded studies which favor steroids over anti-VEGF. I'm sure he can't. Maybe he can maximum manage 1 or 2, and both of them are not RCTs either. So there is a plethora of evidence in favor of anti-VEGF for DME. And yes, he'll say that very bad macular edema, you'll develop exudation, things will become worse, poor vision, worse macular edema, you do know. In Protocol I and in Protocol T, even with patients with poor vision, did much better with ranibizumab compared to sham. And the number of injections. Usual argument is you need so many injections of anti-VEGF, whereas 1 injection of steroid and he's better. No. When combined with laser, especially in Protocol I, the number of injections is much, much lesser as you go down the road compared to any other treatment modality. And the more important thing is the 2-year incidence, the 2-year incidence of systemic problems. Well, they say if you inject anti-VEGF, there's a risk of thromboembolic events. Well, the risk of thromboembolic events with anti-VEGF is the same as risk of thromboembolic events without anti-VEGF events or any other treatment modality like sham. So the risk of TEs is not really high in anti-VEGF as opposed to any other treatment. And then finally coming to what Deepak is supporting, steroids. Well, this is Protocol J, and this has got, Protocol U, and this has got ranibizumab along with ranibizumab and steroid. It is not only steroid alone, it is ranibizumab with steroid. And you do realize that usually these patients, they don't do any better with addition of steroid as compared to ranibizumab alone. And when you really added steroid, not only did you increase their IOP, their vision wasn't any better when you gave them only ranibizumab. And then you have this big talk about hard exudate and how hard exudate will be there and it will go under the fovea and it will scar. Well, this is from the subgroup analysis of RISE and RIGHT trial. There is enough evidence that there is a much greater reduction of hard exudates with, let us say, anti-VEGF alone. And there was no increase in hard exudates, as he pointed out in his very colorful slides, as the DME went down. No, it doesn't happen that way. The baseline visual acuity was not at all in correlance with the presence or absence of hard exudate, and the therapeutic effect of anti-VEGF also was not hampered by the presence of hard exudate. So the presence of hard exudate is not a poor prognostic indicator of a poor visual outcome. And this is one study which I thought, which may offer some solace to him, where there is some effect of a resolution of hard exudates. And this is a sample patient from the study, luckily. And if you look at the one who received steroids, actually they have so much hard exudates. When you have so much hard exudates to start with, obviously it will appear as though it is going down much more. Whereas the third picture is anti-VEGF, where there's not much hard exudate to start with. But remember, this is just with 1 dose of intravitreal steroid versus 1 dose of ranibizumab. So you go to the Bevordex study. The Bevordex study is multiple injections of dexamethasone versus ranibizumab. And both were equally effective in reducing hard exudates in DME. The dexamethasone only initially produced rapid regression of hard exudates, but with prolonged treatment, the bevacizumab arm also caught up with it. And of course, 2 things. Yes, I will mention cataract because we are retinal surgeons when we don't like cataracts. You always have the risk of cataracts. And we have 2 senior glaucoma people in this forum. So risk of glaucoma is always there. So at the end of your treatment session over a period of, let us say, a year or 2, Would you like your patient to have blurry vision with glaucoma and cataract and not able to see your bill? Or would you like to have a patient with very good vision and see the high bill you give him? Yes, steroids probably do have, but there are very, very few and selected situations where we would use steroids, like a vitrectomized eye or a patient who is pregnant, where you do not want to use anti-VEGF, or the very, very, very rare event of the patient being a anti-VEGF non-responder. Otherwise, the safety profile and the efficacy of anti-VEGF is far, far superior to steroid. And Dr. Venkatesh, I think you should actually disqualify his talk because of the next slide. His whole presentation actually he's borrowed from me, and this is the evidence for that. Thank you.
இதையுமா காட்டுறது அநியாயம் பண்றப்ப. Okay. That's an interesting debate. I mean, that's how we debate. Even though now there is evidence for both, I'm sure we'll have to present the right side of it, now from your context and your practice, and also from what evidence you have. And both of them did beautifully. Vignesh, you have any opening comments?
Yes, sir. So, like, we are nice talk by both, like regarding their topics, and it was very interesting. Even though anti-VEGFs have a lot of advantages over steroid, depending on the safety of the ocular safety, but what I have observed is like definitely this dexamethasone implant is faster enough to reduce the hard X-rays in most of the patients, because it all depends on the amount of hard X-rays, how far it is from the fovea. So, like suppose something like a lump of hard X-rays very close to fovea, I would never prefer anti-VEGF, because I have seen in my cases like there's a migration of foveal migration of this hard X-rays, and then a reduction of vision that I have noticed especially in my patients. So, in that context, I would always prefer steroid over anti-VEGFs. Maybe initially, like to reduce the hard X-rays. After that, I will continue with the anti-VEGFs. But even though studies like the studies they have discussed showed that like when both are like more or less equal, but the initial reduction of dense hard X-rays that we see, maybe like the Western population, the studies where they have done, they may not be seeing so much of hard X-rays like we are seeing. Like we are seeing very heavy hard X-rays even with people with normal lipid profile. That is we are seeing in the Indian context, and our patients are like very poorly controlled. I am seeing HbA1c as high as 15 or even 16 I have seen. So average is like average control we are seeing is more than 10 only. So 10 to 16, maybe per se like the diabetic control is so poor. So we may have like more exudation because there is more inflammation. So diabetic retinopathy is a chronic inflammatory disease. So definitely in that case, like hard X-rays as a result of the inflammation. So steroids will definitely have a better role in our scenario where diabetes is very poorly controlled and the exudation is more compared to the Western population where the studies have been done. So, but however, like once the hard X-rays have come down, but I will not be treating with Ozurdex like continuously with maybe 2-3 times then definitely they're going to get glaucoma. Then I will switch over to an anti-VEGF which the patient can afford. But small hard X-rays, like even like little maybe not just extrafoveal, small hard X-rays, maybe we can like both are having equal, like we may not have like that kind of migration. Well-controlled diabetes and the patient is having normal lipid profile. So that case maybe like both are more or less equal. But I mean, especially in these cases like where they're poorly controlled and dense hard exudation, I would prefer steroids rather than anti-VEGFs.
Perfect. Professor R. Segar?
What Arthur was saying, when Arthur was saying if every hard exudate with anti-VEGF goes for scarring, then we'll have millions of scarring in RIO. That much of scarring we don't have. So he was stressing that point too much. I don't buy that. And ஸ்ரீராம் சொன்னப்ப எனக்கு என்ன தோணுச்சுன்னா, எதிரி கையில என்ன கார்டு இருக்கு, அவருக்கு என்ன பிரசன்டேஷன் பேச போறாருன்னு நல்லா இவரே செஞ்சு கொடுத்து அவரை பேச வச்சிருக்காரு. ஆக்சுவலா ஸ்ரீராம தான் டிபார் பண்ணணும், ஆர்த்தர். And but jokes apart, I believe that sincerely that steroid companies need to bring in more into it. Like இப்ப இருக்கிற anti-VEGFல இருக்கிற choice, cost manipulation, biosimilars எல்லாம் வந்த அப்புறம் இருக்கிற அட்வான்டேஜஸ் அதெல்லாம் வந்து இன்னும் ஸ்டெராய்ட்ஸ்ல இல்ல. Steroids, when we offer to the patient and tell them these things, most of the times patient choose anti-VEGF. Usually today's they say like இது முதல்ல போட்டு பார்க்கலாம் சார், இது ஒர்க் ஆகலைன்னா அதுக்கு போகலாம் சார் அப்படிங்கிற மாதிரி தான் most of my patients say. I think that is how it is around. So that again tilts the balance towards anti-VEGFs for this condition also, at least as an initial injection.
Okay. Thank you, Professor. Balaji, are you there? Balaji?
Sir, அதுக்குள்ள நான் ஒரு சின்ன clarification கொடுத்துக்கிறேன்.
Yeah, you can rebut, yeah.
Sir,
And
I'm going to share my screen again.
The WhatsApp message வந்தது இல்லையா?
அந்த வாட்ஸ்அப் மெசேஜ் என்னதுன்னா அதுதான் நான் திரும்ப காட்ட போறேன். ஒரு நிமிஷம்.
அதுக்கு ரீபட் இருக்கா?
ஆமா சார், ஜஸ்ட் a minute.
காட்டுங்க விடுறது இல்ல.
ஒரு நிமிஷம் சார், ஜஸ்ட்
அத வேற போய் ஸ்கிரீன்ஷாட் எடுத்து சேவ் பண்ணி கொண்டாராரு பாருங்க.
அவர் கொண்டு வந்திருக்காரு, அதுதான் பிளான் பண்ணிட்டு.
This is a public forum. Share the correct chat, okay?
Yes sir, yes. ஓகே சார். தெரியுதா சார்?
தெரியுது.
யாரு ஆஃபர் பண்ணிருக்காங்க, யார் லஞ்சம் கொடுக்குறாங்கன்னு பாருங்க சார். I actually have an old PPT. You can have it. நான் கேட்கல சார். அதுவும் கேளுங்க சார், இன்னைக்கு வரைக்கும் அதை எனக்கு அனுப்பவே இல்லை. அனுப்புங்கன்னு சொன்னேன், அனுப்புனாரான்னு கேளுங்க. இது நான் ப்ரிப்பேர் பண்ணது. கவுத்திருக்கு பாருங்க.
இல்ல, but you chose wisely actually, finally, to make your own presentation. I'm sure you read through it, and then we always learn from
these. Totally made by me, not set by Dr.
Exactly, that is where we learn. Now, once you start seeing, then you learn. Then you see, then you listen to the wisdom of others' practice also.
Yeah, true.
It's so nice. So we'll go to the last debate.
Sir, I just want to add one point, sir.
Yeah.
Sir, like all these diabetic patients, like because of their poorly controlled status, most of them are having a diabetic nephropathy also. So in diabetic nephropathy, anti-VEGFs are known to increase the proteinuria as well as worsening of diabetic function. So in those cases, like diabetic nephropathy, always steroids having an edge over. Steroids are the choice because we don't have other choice, because this anti-VEGFs, especially when we send this nephropathy patients to nephrologists for getting fitness, most of them advise us to avoid anti-VEGFs because they are known to worsen the renal function over a period of time. So when already they are under in this kind of problem, like we have to use steroids in that case, and maybe minimize the use of anti-VEGFs so that progression is stopped. Just I wanted to add this point also. Thank you.
Thank you, Gopal. Any quick rebuttal from you?
Nothing really. Only thing is yes, I do agree steroids probably reduce hard exudates faster, but there is also one bias where we tend to use steroids more when there is more edema and more hard exudates. Because we also always want that instant, both the doctors and the patients. I'm not blaming the patients alone, it's both the patients and the doctors. We want instant gratification. We want it to work quickly. We don't believe in that thing of treating it step by step and it's slowly reducing. We don't want to tell the patient you'll need multiple injections. We don't want to tell the patients there is no single wonder injection which will cure him. A lot of patients who come after an injection to me or go to anybody, invariably the person who did the first injection hasn't told them that he will need multiple injections. So be it steroid also, even steroid I'm saying, like what Dr. Vignesh was saying, multiple injections of Ozurdex he doesn't give. Even whatever it is, you will have to, the biggest problem in this debate between anti-VEGF and Ozurdex or any steroid is, there is no real RCT where you've given both in the same frequency and tried the frequency in it, which should be given. Always they try multiple anti-VEGF with single steroid or single anti-VEGF and single steroid. The disease doesn't work like that. It needs treatment for at least a year or two, at least 3 to 4 injections in the first year, lesser in the second year. And along with good diabetes control, that what Dr. Vignesh was stressing. No good diabetes control, even a steroid is not going to work well. So end of the day, that is what matters. Good diabetes control, and tell the patient he will need multiple injections, whatever you're doing, be it steroid, be it anti-VEGF.
Thank you, Gopal.
Venkatesh sir.
Yes, sir.
இப்படியே குழப்பி கடைசியா நம்மளால ஒண்ணும் பண்ண விடாம பண்ணிடுவாங்க சார். ஏதாச்சும் ஃபைனலா ஒரு முடிவுக்கு வந்தாங்களான்னு பாருங்க சார்.
ஒரே ஒரு பாயிண்ட் இது நாட் எக்ஸாக்ட்லி இந்த டிபேட் லேசர்னு ஒண்ணு இருக்கு, அதுவும் சேர்த்து போட்டீங்கன்னா இதெல்லாம் குறைக்கலாம். நிறைய பேர் அது ஒரு மறந்துட்டோம், அத கொஞ்சம் அதையும் மனசுல ஞாபகம் வச்சுக்கங்க. ஏன்னா பாதி ரிப்பீட் இன்ஜெக்ஷன்ஸ் பெரிஃபரல் இது நான் பர்ஃபியூஷன் பயங்கரமா இருக்கும். பேஷண்ட்டுக்கு இது போட்டாலும் சரி, அப்புறம் போட்டாலும் சரி, 4 வாட்டி 5 வாட்டி போட்டாலும் திரும்ப வரும். ஒரு எஃப்எஃப்ஏ பண்ணானா பெரிஃபரியில சுத்தமா பர்ஃபியூஷனே இருக்காது. அதுக்கெல்லாம் லேசர் பண்ணீங்கன்னா டக்குன்னு குறைஞ்சிரும். எல்லாமே இல்லை, there is a significant but small proportion of patients who definitely require good laser. We
Balaji,
tend
I
to
think
forget that.
you didn't hear my presentation. I did have a slide on protocol I where number of injections significantly reduces with prompt laser compared to deferred laser. There was a slide there.
Perfect.
We don't teach our PGs laser anymore, which is actually very sad. It's still a very, very useful method of intervention.
It's becoming suturing now. Nobody wants to practice suturing these days, right? So nobody wants to.
Dr. Satyan, one quick point to Dr. Satyan. Satyan, steroid கொடுக்குறோமா glaucoma வருதா உங்களுக்கு கேஸ் வருதான்னு நினைச்சிட்டு சந்தோஷமா இருக்கணும். இப்படிலாம் கேள்வி.
Remember that this is recorded and it is also streamed on YouTube. It is going to be there. But anyway, apart from all the interesting jokes, we'll have the final debate. Low dose atropine in myopia. We are going to have a team which is going to fight for the pros and the cons. So pros, we have Shruti Nishant, who is going to talk about the pros of using low dose atropine. Yes, Shruti.
A very good evening to everyone here. So we are up for the last big fight of today. So we're going to be discussing whether low dose atropine for myopia actually works or not. But I don't know why this big confusion about whether it works or not when the answer is very clear. So I'm here to make it very simple that low dose atropine absolutely works. I'm going to change the title of my talk to Let's Keep It Simple, so that I'm going to prove it to you why it is so simple that atropine is actually the best strategy forward. Okay, so we know that there's one study from Brian Holder Institute which talks about 50% of the world's population is going to be myopic. But here I'm going to show you one graph which shows that 50% of the Indian population may end up becoming myopic by 2050. And this is from all the Indian studies that have been correlated and projected to have this effect. And not just that, we are going to have the most productive age group of our population going into myopia. So just as we were discussing about diabetic retinopathy, we are going to be slowly discussing about myopia and its complications in the next 2 decades. So having said that, in the future, we are going to have more Anjali Papas and more Tari Zamipar boys having Kannadis rather than having other issues. So from gone are the days when every child is special. Now we are worried that every child is going to become myopic. So in this background, atropine came in as a wonderful drug, as a wonder drug to promote or to retard myopia progression. So how does it work? The latest studies suggest that it does not work on the accommodation. It in fact works on the retinal receptors, and it acts by increasing the dopamine output. So this is a study where they took vitreous samples from eyes which were myopic and also eyes which were treated with atropine. And you can see clearly the eyes which were treated with atropine had a higher concentration of dopamine. Now we all know dopamine is our happy hormone. Now in this day and age, I feel we need enough of happy hormones in our body to combat all the stress in our life as well as the progression in the myopia. So let's move on to efficacy of the drug. Now, this is a standard chart that is shown from atom studies. This is the atom 1 and 2 put into one single chart. You can see that this is the placebo arm where nothing was done for the patient. And this is the 0.01%, which was found to be the most effective and the safest. And clearly, you can see almost a minus 1.5 to 2 diopter of protective effect over a period of 2 years. Now, if this isn't called success, I don't know what is called. You can see there is a 50% protective effect and almost minus 1.4 diopter less at 5 years. And the protective effect is almost 60%. And this is really a significant amount. Now, if we cannot look at this as success, I don't know, maybe Dr. Frederick sir is waiting for us to, sit and smile, wait patiently to see if something happens or not, where the axial length keeps on growing and growing and we just keep on sitting, waiting patiently. This is one thing, but now in atropine itself, we have so many concentrations that are available and so many choices available in order to taper and titre and give to our patients. Now, earlier we were only having the 0.01%, which gave a protective effect of minus 1.12 diopter over 2 years. This is the LAMP study I'm quoting. Here you can see 0.05% has now come in, which is giving a protection of 0.5 diopters protection. Now, this is really amazing. So earlier we were having 1 star performer 0.01%, which was giving excellent, but now we are having the same star performer in a different avatar giving even better results. So I think the options and the efficacy keeps on getting better with more studies coming out. Now, if we compare it with the other options that are available, this is the DIMS lenses, and these are the studies that were done on the DIMS lens. And here you can see, this is the LAM study which spoke about, I want to bring your attention to the second one. Here you can see at the end of 3 years, they had a refractive error protection of 0.52 diopters and an axial length protection of 0.3 mm. Now I want to compare it with our study that we did here. At 6 months, the DIMS lens, we had 12 patients who had DIMS lens used for over a period of 6 months. We found a protective effect of 70% with a refractive error of 0.2 diopters progression only over a period of 6 months and an axial length change of 0.1 mm. I agree it is good, but now I just wanted to look to the side where this is the dilute atropine patients that we have been giving over the past few years. You can see we had studied 68 eyes. We had a success rate of 82% as compared to 70%. The mean refractive error change was only 0.12 diopters, and this is after almost 1 year of waiting, and the axial length elongation was the same as that of DIMS, which is 0.1 mm per year. Now this is Sasta or Tikau, which means that at cheap, we get the same result as that of the DIMS lens, if not better. Now, many people would say that 2 years, how do we give the drops? Will they put the drops? It is actually quite astounding to see that most of our children whom we give atropine, dilute atropine to actually do very well. They actually use their bottles very well, and the side effects are quite minimal. If you see that even in the study, the ATOM study, only 6% of the children actually required glasses. Otherwise, most of them were comfortable without any bifocals. It has minimal effect on pupillary diameter. It has minimal effect on accommodative amplitude, and it also caused a tear film. It doesn't cause any tear film instability. So that's another additional point. And here, this is the icing on the cake. If you see, this is a study where they actually looked at the psyche of the children who underwent 2 years of atropine therapy, and they actually found out that the children who underwent atropine therapy for 2 years were convinced about its efficacy, had greater self-esteem, and actually recommended it to their peers. Also, when it comes to rebound, there is a small rebound with atropine, but so is the case with DIMS. And even after the rebound, the effect is still much better than placebo. When it comes to adaptability, I feel dilute atropine is the most adaptable as compared to the other options in the market, because you can use it for unilateral progression by giving it only to one eye, whereas glasses you have to give both eyes. It can be given to squint patients because the other lenses need a central fixation. We can give it to any amount of refractive error because the other lenses have a cap on -10, that is the maximum can be given. And actually you can use it as a combination therapy. Now there are several studies where atropine has been used in combination with contact lenses, with DIMS, and as well as with orthokeratology, and they have found excellent success. You can see when they have a synergistic effect with the other modalities, thereby bringing better results. Now, from all of this, it's very clear that atropine is that one good friend who always sticks by you no matter what. So if Dr. Frederick thinks that, oh, this he's the one good friend who always sticks around. So he is low-dose atropine who's always sticking up for you and who's always there as the most cost-effective option. Again, coming back to the cost, this is a study where they did a cost-effective analysis, and they found out that dilute atropine is one of the most cost-effective treatment strategies available. For Indian market, one bottle costs around 200 rupees. If you multiply it for a 2-year therapy, it is around 4,500 for the entire treatment. And I think it is worth it because when you compare it with doing nothing, we are left with a very expensive or a very expensive mistake in the future, such as high myopia, versus other options which are almost 15,000 plus for one pair of glasses. So I think when we're looking at other options in the market, I think half our pockets will be empty by the time we finish our myopia control strategy. So this is going to be my last concept. When we are looking at all these expensive options available to take these pens to space, the simple option here lies that a simple pencil can actually do the job. And that's the job that dilute atropine does for us. And we have a confusion on whether to go for one type of lens or whether to go for a second type of lens, which will cause myopia progression, retard myopia progression. And here we can see Dr. Frederick is very confused as to which option to choose. Should I choose or not? Should I give glasses or not? I think the best way forward is just to use a simple solution called low-dose atropine. It's there, it's available. It's just keeping it simple. It's the most effective strategy that is available. And with all due respect to Dr. Frederick, who's my senior and my teacher, and I have learned so much from him, this is just in a lighter vein. So to conclude, dilute atropine is the most effective, safest, cost-effective, and adaptable kind of strategy that is available. So whenever you have a doubt whether to choose atropine or something else, always choose atropine. Thank you so much.
Thank you, Dr. Shruti. Frederick, கண்ணாடி கடை மூடுங்கன்றாங்க. நீங்க மூட முடியாதுங்கிறீங்க, ஏன்னு தெரியல. But let's see your part of it.
Slides தெரியுதா சார்?
Yeah, perfect. இன்னைக்கு வடிவேலுக்கு கொண்டாட்டமா இருக்கு, என்னன்னு தெரியல.
ஆமா சார்.
Nice shaker.
Atropine in myopia control. Our view about myopic control has been very myopic in the sense that we have only concentrated more on the defective vision, and the parents and the patients are more bothered about the cosmetic problems. So we always told the children, like, wear the glasses and you will become like these personalities. And for the parents, we told them, like, no problem, after 16 years you get your child LASIK and you will be glass free. So we continually ignored the myopia progression, which had its effects on other parts of the eye, like cataract or a retinal detachment or myopic maculopathy, which is quite high. And in this context, atropine in myopia control is very significant. Why atropine? It has a lot of other, it's not a very good drug. It has many side effects, both in the eye as well as in the whole system of the body. So when you start atropine, you tell the parents regarding the side effects. This is what the reaction that they usually get. So we as pediatric ophthalmologists also are very concerned about febrile seizures when we prescribe atropine during cycloplegic refraction. So it's not a very good drug to consider. But considering the use, we'll go into the data and see whether there is any evidence available. As Shruti told, Atom 1 and Atom 2 studies were the very landmark studies that we'll be talking in this talk. These were studies where long-term prospective randomized controls were done. In Atom 1 study, they used 1% atropine. They had two wings. So they had one wing where they used atropine only in one eye, and the other eye was kept as a control. While in the other group, they had the placebo drops and the other eye as a control. So even though, as far as atropine 1 was concerned, they concluded that from Atom 1 study, they were well tolerated. But actually, when you go into the data, there was 4.5% hypersensitivity reaction, glare 1.5%, and blurred near vision. And IOP changes were also very high, within 5.5 millimeters of HG. And you should note that only one eye atropine was used. And when it comes to systemic absorption also, you will see that this red dot, which shows the atropine untreated eye, even though the effect is very minimal, there is some effect, and definitely there is a systemic absorption which cannot be ruled out. And here also I want to emphasize that only in one eye atropine was used, while what God only knows what could have happened if they use it in both eyes. So now atropine percentage was a problem. So this is how the researchers reacted. So this is how the Atom 2 study came into being. So because they had a lot of complications with 1% atropine, they decided to use lesser percentages. So 0.5%, 0.1%, and 0.01% was used. And they did find the side effects like allergic conjunctivitis and dermatitis in the 0.1% and 0.5% groups. And it was very surprising and also hearty to see that the 0.01% group had no side effects. Actually, they used 0.01% as a placebo group or a control group. So even though there was no side effects, now the major question is whether it had any drug which had any effect on
myopia. So we'll go dwell into the details to see there is any evidence, strong evidence. So before that, I just want to say the incidence and progression of myopia in school children. So a Singapore-based study. So they said that the cumulative 3-year myopia progression rate in 7-year-old was higher compared to that of a 9-year-old with a significant p-value. So largely it said that as age increases, the myopia progression decreases. So with that, 0.01% is what is now being used. So what are the risk benefits of 0.1? And mind it, we are using it with our children, and it's going to have effects on the subsequent generation, and whether these decisions are based on robust data. So this is the ATOM 2 5-year trial data which came, which said that, which main outcomes were the changes in the spherical equivalent and the axial length over 5-year period. And it very clearly told that 0.01% slowed myopia progression by 50%. That was a very, very tall claim, and we'll see whether the data was correct. And in this, you don't have to get confused too much. There are only 2 lines which you need to concentrate. This is the placebo eye, I mean, this is the control eye, and this is the 0.01% eye, and this is the 2.5 years data. So why this line is drawn is, you will see that the control group was seen only till 2.5 years. And at 2.5 years, they concluded that minus 1.4% increase was there in the control group. So they concluded that, but the 0.01% group, the same minus 1.5 diopter decrease was seen at 5 years. So 5 years and 2.5 years, they divided and told that it is a 50% reduction. Or to put it in other way, there was no control group for the rest of the 2.5 years. So they assumed that 1.4 diopter increases at 2.5 years, and at 5 years, it will become double. And so they told 2.8 and 1.4, and hence the data was concluded as 50% reduction, which was, the assumption was also wrong, because as age increases, myopia decreases. So this graph need not go straight down. So coming to the next point, rebound phenomenon. They talked about, it's about stopping atropine and then the progression of myopia after that. So actually 0.01% was chosen to be used commercially because it had a very, very less rebound effect as told in the studies. But actually speaking, when you break down into data in the age group 6 to 8 years, 0.01% had 62% rebound phenomenon, which was very, very high. And as the age progressed, the rebound phenomenon decreased. So as the age progressed, myopia progression also decreases. So we don't know whether it is the effect of the drug. And before going to the next slide, the most significant conclusion of ATOM 2 was the axial length decrease. And we all know that as axial length increases, the spherical equivalent also increases. But in 2018 in JAMA Aftal, Mark Bullimore very clearly told that there is a big discrepancy between what was claimed. 0.01% has no effect on axial length or very minimal, despite its sizable effect on the refractive error. So yes, atropine mechanism is still a myth. They say that it acts on the muscarinic receptors M1, M5 and has effect on the retina and the sclera and reduces the axial length and thereby reduces the spherical power. But there is no robust data to support it. And they have proposed other mechanisms like effects in the eye or with respect to development of cornea or induction of defocus. But whatever it is, even in the eye, we really don't know what is the long-term effect of atropine and what about the systemic effect and the long-term effect in our children is left to a big question mark. So summary, atropine concentration is still a confusion. There is no data on duration of usage, like you start a child at 9 years or 6 years old, till what age you are going to continue the medication. No data on rebound effect after long-term use. No data on method of stopping the drug, whether you stop it abruptly or you taper it and there is no definite data on long-term side effects. So even if long-term, if they prove that atropine is quite effective in long-term, what about compliance? And you should remember that we are treating young children and teenagers, where the compliance is going to be a very, very important and big issue. So conclusion, should we give more attention to non-intervention treatment like progressive glasses, DIMS, HALT, or even go to the basics like lifestyle modifications, more outdoor term, less screen time for entertainment? So in this context, this is the present scenario of atropine in controlling myopia progression.
Frederick, unfortunately, you have not shared the audio for this, so people are not really able to correlate. But anyway, you finishing up?
Yes, sir. So finally, the important rule is to do no harm. So as physicians, when we are making any decisions, we should rely on robust data, and that should be our gold standard. And depending upon that only, we have to take decisions. And mind you, our children are involved in this treatment. And with that, I rest my case. Thank you.
Thank you very well. Sorry, thank you, Frederick. Anyway, we are on time now. We'll open it for the last discussion. But Satyan already குழப்பத்துல இருக்காப்ல. ஏன்டா நீங்க வந்தோங்கற மாதிரி இருக்காப்ல. எதை practice பண்றது தெரியாம. But that's what the real idea of debate is. Now, when you debate, you see the pros and cons, and I think beautifully all the speakers have put up the pros and cons on both sides. And there are some areas where some team has spoken for the other team also. Thanks to Prabhu and Naveen, who have done a great job complimenting each other. But any discussion on the last topic and final comments by our chief judge, who's just joined? Ella stalum paathutingla sir?
Ella, I've been seeing all the debates, and I think, in my opinion, all the 5 debates were very good. And all the 10 debaters, all the 10 fighters are winners. And the last debate, particularly what Frederick told, is very important. I think Shruti stressed a very important point. But as you all know, myopia is a multifactorial. So you need to take care of all the points and all the factors. And that's what he stressed upon. And then each and everybody has got a very important, take-home message. And I learned a lot, seriously speaking, Venkatesh, and thanks to you for coordinating this entire big fight. It was very good, and all the topics were well chosen as well, and very good discussion. So I was not able to talk. I was listening to all of them.
Thank you, Judge. I think நீங்க சாலமன் பாப்பையா மாதிரி ஜட்ஜ்மெண்ட் கொடுத்துட்டீங்க இன்னைக்கு, கான்ட்ரோவர்சி இல்லாம. பட் இண்டிவிஜுவலி we had some.
Actually, அப்படிதான் இருந்தது வெங்கடேஷ், because they had scientific evidence for each and everything. For example, if you take FACO, you have this thing wherein you can do FACO, you can do the SICS as well. So scientific evidence for everything was there, and if you have to give it to them for all the 10 debaters, I would say.
Thank you, Judge. I'll give the last.
Dr. Mohan Rajan.
Yes, sir.
Venkatesh has chosen topics which are actually never-ending debates.
Yeah.
Absolutely.
I think every topic is actually a never-ending debate. You can keep debating.
Lovely topics.
So it's
very
all never-ending debates.
ரொம்ப கேர்ஃபுல்லா ப்ரௌஸ் பண்ணி எடுத்தது கோபால். எல்லா
ultimately வந்து what works best in your hands you do. That is what. Okay, what works best in your hands, of course, with some scientific evidence also. I think that is the message you want to give all the delegates here.
I give the last.
எப்படி நினைப்பேன்னா, MR sir, a good debate is a debate which leaves you with more questions. It doesn't leave you with more answers.
More
it in fact leaves you with more questions. அந்த வழியில வெங்கடேஷ், this is a very nice debate, and I congratulate the whole team for putting this up together.
Thank you. Dr. Sharbila will give you the closing remarks. Yeah.
Good evening, everyone. On behalf of TNOA, it's my privilege to propose the vote of thanks for this amazing session, The Big Fight. It was truly a clash of the titans, and thanks to President Ramakrishnan sir and Chairman Atik and ASC Chairman Atik and Moderator Venkatesh sir for coming up with this session and the topics which were really interesting and practice oriented. And it was truly a clash of the titans with speakers from every subspecialty speaking for and against the particular topic that was and it was very interesting to see all the speakers. All the talks were supported with robust clinical data, and they were all on time. I think this is the first session which finished on time. Thanks to moderator Venkatesh sir for carefully, wonderfully moderating the session, and thanks to the speakers, Haripriya ma'am, Paneer Selvam sir, Dr. Madhavi, Dr. Naren, Dr. Prabhu, Dr. Frederick, Dr. Shruti Nishan, Dr. Deepak Author, Dr. Sriram Gopal, and the jury, Paneer Selvam sir, Dr. J.K. Reddy, and the chief jury, Dr. Mohan Rajan sir, who joined in the last minute. Thanks to the tech support, Numerotech, Sai, for perfectly coordinating this session, and thanks to our sponsors, Aurolab. Thanks to everyone who made this a wonderful session for the practicing ophthalmologists. I'm sure we'll all have the pros and cons in the mind and take an informed decision based on what the jury and other speakers said. Thank you, everyone.
Thank you. On behalf of the president, who is celebrating his granddaughter's first birthday. So somebody has to go and switch off his phone. Now he's not there. I invite you to Kutralam. So he has again asked you to pass this message, and all the people who are watching, the TNOA members, it's going to be a good show. We're going to have a 3D show also there for the first time in TNOA. Welcome. Thank you.
The rooms are still there, so please register. I think the registration date is still extended and the rooms are still there. So I think Dr. Sriram Gopal, it's still there, right? I think sir wanted to make that request as well. Please do register for the mid-year meet. Thank you, everyone. Good night.
Thank you. Thank you.
Thank you. Good night.